All right, everyone. Thanks for tuning into this. This is Ryan O'Malley. And this is the first part of a two-part lecture about inflammatory bowel disease. Part one is background and technique. Part two will be about reporting and imaging findings. So for this part one, we'll talk about the background of IBD in general, and we'll talk about why we use imaging in IBD and how the spectrum of Crohn's disease specifically and the various stages of activity apply to how and when we image them. Specifically in that regard, we'll talk about how to use CT enterography and MR enterography with a discussion about the technique and specific for MRE, what sequences are used for what purpose. And then lastly, we'll talk about when you might consider CT enterography versus when you might consider MR enterography. I also sent out an article as a companion to this talk that I think is good either as a prelude to read before watching this lecture or potentially afterwards from the Society of Abdominal Radiology, a consensus guidelines about the imaging technique from the disease focus panel of the SAR. I think this is a good one to save to help discuss the different techniques and the justification for different types of tech or the different way to image IBD and the rationale for why. So by way of background, talking about imaging in the setting of inflammatory bowel disease, imaging has really become primary in assessing inflammatory bowel disease. It's part of the diagnosis, the assessment during treatment, and when changing different types of therapy. And it's a key metric that is complementary to the clinical endpoints and endoscopic endpoints. Historically, we used to think of Crohn's and ulcerative colitis as two separate entities with distinct phenotypes that are listed here, and that their overlap between them was relatively uncommon. But the reality is that there is significant overlap, and there is a significant percentage of patients that present in an indeterminate category initially, where the clinical features or the endoscopic features or the imaging features are not necessarily definitive for ulcerative colitis or Crohn's disease. So many of these patients are treated based on the best available information at the time, but their phenotype may change during the course of their clinical observation. And so as a result, many patients who are initially treated as ulcerative colitis and get an ileal pouch or then subsequently the diagnosis subsequently changes to Crohn's disease and the management subsequently changes. And in this publication listed here, Farmer et al., when the pathology was reviewed by a subspecialty GI pathologist, the diagnosis was changed in as much as 45% with a relatively high discordance rate. So we have to consider that the imaging has a potential role to really help clarify in these situations or help definitively diagnose a patient as Crohn's or ulcerative colitis. And so what we're really looking for are there distinct imaging features that help decide that it's one versus the other. So how good is imaging right now for detecting IBD and Crohn's specifically? CT enterography is both CT enterography and MR enterography are highly sensitive and specific. You see the actual numbers listed here, both in the 80s and 90s percentages for both. And more recently, MR enterography was compared directly with CT enterography and shown to be non-inferior. So I think they're both very good imaging tests for this role. And historically, and still for the most part, imaging is complementary to endoscopy, but in some cases it might actually be a better choice. There are many patients who have transmural disease or extramural disease that is not visualized endoscopically. For example, patients with strictures or deep intramural disease. There are certain studies, including the ones listed here, where there's a significant percentage of patients that have a high percentage of undetected disease that was seen only on imaging and was not seen on endoscopy. And so a significant percentage of patients may actually have an upgrade in their disease severity based on the imaging findings, which can alter management. So it's an example here of a patient with Crohn's disease where you see the active inflammation on the CT and on the endoscopy, but what the CT shows that the endoscopy does not see is this extramural collection and tethering and interloop fistula, which is only detected by CT. Similarly, here's another patient that had multifocal stricturing and a stellate configuration where loops were tethered together, also only visualized by imaging. One note specifically regarding CT enterography, over time we've accepted that diminished image quality is okay, and specifically in this patient population that is radiation sensitive, most of these patients are young and highly likely to undergo repeated imaging during the course of their disease. And so we have found that progressively decreasing the dose is acceptable for diagnostic purposes. And even though the images may not look as good for us, subjectively anyway, the accuracy does not suffer as a result. And so we have a variety of different techniques for dose reduction in CT enterography that can be utilized in this patient population. Specifically regarding CT technique, oral contrast is a critical portion of the protocol, and the ideal agent on CT is one that will distend the bowel throughout the entirety of the GI tract, and ideally involving both the small and large bowel, and that's also well tolerated by patients so that they can actually complete the entire oral prep. For most patients, CT enterography oral contrast material is either Volumen or Brisa, both of which are negative or neutral oral contrast agents. Positive enteric contrast in CTE has a limited role, specifically in the early postoperative period, same as any postoperative GI patient where we're looking for an anastomotic leak. These are better detected with positive oral contrast, but for most other patients, a negative or neutral oral contrast agent is the right choice. So it's an example comparing positive oral contrast and negative oral contrast side by side in the same patient. And you see there is wall thickening that you can see here with the positive oral contrast material, but it stands out and you see the extent a lot better with improved distension and more of a contrast between the wall and the contrast agent. Here's an early postoperative patient, image on the left, without adequate opacification of the affected segment with oral contrast material. And on the right, you see the oral contrast material with a defect in the wall and an anastomotic leak or perforation postoperatively. For MR enterography, the same principles apply. You want adequate distension of the entire GI tract so that you can clearly see both sides of the wall so that you can characterize the mural enhancement pattern and have sufficient contrast between the lumen and the wall and confirm that something is real wall thickening as compared to just an underdistended segment. So same principles. You want good distension throughout the GI tract, ideally something that is hyperosmolar and non-absorbable. That's what achieves the distension throughout the GI tract. But same as for CT enterography, you want something that patients will actually tolerate and that is practical for them to drink. For MR, we talk about biphasic contrast agents, and here's where MR differs from CT. Biphasic meaning it is low signal intensity on the post-contrast T1 weighted images, but high signal intensity on the T2 weighted images. This allows for characterizing different or complementary features on the MR enterography. It's low signal on T1, so you can see the mural enhancement pattern, and it's high signal on T2, so you can see the wall thickening, same as CT enterography. MR enterography protocols have been a moving target over time, but I think we're to a point now where they're reasonably standardized, both at our institution and externally. They combine a complement of fluid-sensitive and post-contrast sequences, including some that are acquired very rapidly so that you minimize any bowel motion and you ensure that the luminal distension you've worked hard to achieve with your oral contrast agent persists through the scan. One problem that is unique to MR enterography is bowel motion. With a patient on the table for 30 or 45 minutes, the bowel at varying stages of peristalsis. Usually this requires pharmacologic bowel paralysis, which is given right before the post-contrast sequence, which is the most motion-sensitive sequence. At the bottom here, I've listed the sort of key components of a standard MRI enterography component with the same reference that I mentioned at the beginning of the talk. An MR enterography protocol usually includes some fast T2 weighted sequences, either single shot fast spin echo or haste sequences combined with fat suppressed T2 weighted images, a balanced gradient echo sequence, Fiesta or True FISP are examples of those, plus pre and post contrast dynamic imaging, axial and or coronal. So we'll talk about all of these here. These are the accelerated T2 weighted sequences. These are the best sequences to assess the bowel distension, and with that, evaluating for bowel wall thickness and bowel wall edema. These are sensitive to motion as well, so these are acquired generally very rapidly to minimize bowel motion. This is an example where you see wall thickening. Then within the wall, you also see this high signal intensity, the intramural edema, which is a marker of more severe bowel wall thickening. The fat suppressed T2 weighted sequences are complementary to the non-fat suppressed sequences. These highlight the inflammation and intramural edema and make them more conspicuous as compared to the non-fat suppressed sequences, particularly in the mesentery. So you see side by side the same patient, non-fat suppressed on the left, fat suppressed on the right. You see the intramural edema on both, but the peri-enteric edema or the mesenteric fat stranding you see much better on the fat suppressed sequences. Same thing here, it just makes the bowel wall edema a little bit more conspicuous. Same patient side by side, you see some high signal within the terminal ileum on the non-fat suppressed image on the left, which stands out a lot more on the right when you add the fat suppression. And lastly, another patient here where you have distal bowel wall thickening. Same thing, you see a lot of high signal around here, but in this patient who has relative paucity of mesenteric fat, it's hard to know whether this is fluid around this bowel or just normal fat. And when you use fat suppression, you can see that this was just fat that is now nullified, but this high signal here persists, indicating that it's peri-enteric edema. Balanced gradient echo sequences are very fast, and so these are best for eliminating motion artifact and also in the same way as the T2 weighted sequences demonstrating bowel wall thickening and mesenteric changes. One thing to note is that these are a mixed T1 and T2 signal sequences, and so you should not use these for characterizing lesions based on. So if you're noting lesions in the kidneys or the liver or anywhere else, you should be correlating these with the other sequences and not using the signal on the balanced gradient echo sequences for definitive characterization. These are all, since they're fast and there's minimal bowel motion, these are also the sequences that we use to acquire cine loops to assess for bowel motility. I think these are useful for sort of as a small bowel follow-through equivalent to assess the bowel motion, either normal or hyper or hypo peristalsis. And then the last kind of workhorse sequence as part of a core MR enterography protocol is the pre and post contrast imaging. This is the key sequence for assessing the bowel wall enhancement pattern, the mesenteric vasculature for any hypervascularity or comb sign, interloop fistulas, abscesses. As I mentioned earlier, this is the most susceptible to bowel motion, so usually these are acquired after a bowel paralytic. In our case, usually glucagon, although it can be a variety of other agents. And then lastly, in axial post-contrast imaging, these help co-localize findings that we see on the coronal or that you see on the T2 weighted sequences, incidental findings in these cases showing the bowel wall enhancement pattern in the affected bowel loops as well as an interloop abscess. One other note about the post-contrast sequences, usually the dynamic post-contrast images are acquired in the coronal plane because most patients are thinner in the coronal plane. So it's a shorter acquisition to acquire it as compared to the axial plane. Diffusion weighted imaging is commonly used, although not universally. It's becoming more part of the standard. It's very sensitive and specific for bowel inflammation, and there are many publications showing that restricted diffusion correlates with other markers of active inflammation and with the post-contrast features. And when it's present, it usually indicates more severe active disease. And so for practices, they use it. We often incorporate it as an additional feature or a tiebreaker. There is recent publications or recent work showing that it is non-inferior to a post-contrast MR enterography. And so this, I think, is particularly valuable if you have a patient who can't get gadolinium. You can kind of use the diffusion sequence as a surrogate for the bowel wall enhancement pattern. And there is potential that this in the future could be used as a quantitative marker of inflammation. I alluded to this earlier in the balanced gradient echo section. This is how we acquire our cine loops. I think this is a useful sort of adjunct to just get an overview of the bowel wall or the bowel motion, and in particular try to identify any hypoperistalsing segments like the one indicated here with the arrows. These are a few novel or optional sequences that you'll find in the literature. Magnetization transfer is a way to calculate the MT ratio and identify tissue collagen deposition in cases of suspected strictures. Hybrid PET and MRE has also gained interest recently as an additional potential biomarker when trying to discriminate between fibrosis and active inflammation. The question of when to use CT enterography and when to use MR enterography is one that commonly comes up in our practice. At our institution, most of our gastroenterologists use MR enterography. We have actually very few CT enterographies. That varies by referrer and varies by institution. So depending on where you end up practicing, that trend may reverse. I think in general, they're complementary and roughly equivalent to each other. But CT enterography is probably better for older patients who you don't have to worry about added radiation dose, and definitely better for patients who present acutely, since it's a very short examination. For anybody who's nauseated or vomiting or acutely ill, it's much easier to get a CT done as compared to an MR. And for many patients, as part of their first exam, a CT is probably a better choice to rule out any other potential confounding diagnosis. By contrast, MR enterography is better for young patients, and especially as they're undergoing therapy to assess for response to therapy. MR is also better for characterizing known perianal disease and for identifying small fistulas that might be occult on CT. Anybody who has an IV contrast or an iodinated IV contrast contraindication, particularly patients who are pregnant, MR is potentially better. That is a scenario where you might consider or where you would consider doing it without contrast. A non-contrast MR is much better than a non-contrast CT. So in summary, in modern practice for taking care of patients with inflammatory bowel disease, imaging is a key component for both the diagnosis and assessment of treatment response during therapy. IBD is a dynamic continuum of disease, with some patients clearly in either the ulcerative colitis or Crohn's disease categories, but a significant proportion showing findings of both, and imaging can sometimes help be the tiebreaker for those patients. Imaging is highly accurate for patients with active disease, and the protocols have become relatively streamlined and standardized now, such that any abdominal imager should be familiar with both techniques and when to use MR versus CT. That concludes part one of this series. Please refer to part two for the imaging findings and examples.